Good afternoon, and thank you all for joining us for this medical education session. And I especially thank Dr. Narmada, who's just shared her insights into a combined activity. So I'm going to start my talk with talking about when UDHAVI was needed. UDHAVI literally translated from Tamil as help. And these are my reflections from the CMC telephonic helpline for Vellore and neighboring districts during the second wave. So I'd like to start with thanking everyone who made UDHAVI possible. A note of gratitude for the unhesitating help, Dr. Narmada and Dr. Madan and the entire IMA Vellore team. Thanks to the Vellore Institute of Technology. The UDHAVI group, about 100 of us or so. Thanks to Arun Zachariah, the Vipmar and their team for all of the telephonic links and all the technology. And thank you to all our partners, Hope House, Sets India, Rotary Vellore and the Pisces Group. So the outline, of course, started in the second wave when this photograph actually created controversies. It was taken from outside our emergency department, and truly there were no beds. So I will talk about the concept, the formation, the execution, and the completion regarding UDHAVI. So on May 1st, 2021, the spark was lit. A group of us from CMC had a Zoom meeting with various doctors, as mentioned there, who were practicing home-based care for COVID-19 since the first wave. It's just a thought, just a suggestion. And the next time, within the first week, few things happened. The first CMC group was formed, including people from the departments mentioned. Amongst this, we also realized that we had instances where the second wave had already hit and there were a lot of problems like in Delhi. And there was a helpline set up in Delhi, which few of us were a part of, where they had already started helping patients who could not find beds. And this was a clinical helpline, and based on these lessons learned, it really was useful for them. Also, within the institution, we were thinking of broad guidelines for care of mild to moderate disease at home if hospital beds were full. So this literally actually happened with the following week. The team expanded, they looked at lessons learned from other groups and also what was happening within the institution. And then, of course, the crisis struck. What was happening in other states was happening here. So by the end of the first week of May, what was initially called as the Connect Community Outreach Network for Non-Hospital Empowerment for Compassionate Component COVID Treatment was changing into something little different. We realized our strengths and weaknesses, where we could be strong on information and giving guidance and putting in practices. On the ground, we also needed help. That would be expanding the group to include our own outreach referral centers and also to include the Vellore IMA. So we coined the term UDHAVI. It happened actually over a few hours, and it was consolidated, as I will discuss later, including medical, non-medical staff, the Vellore IMA, and many, many others who I've thanked earlier. So how did the spark grow? We had a CME which included home-based care concepts with the Vellore IMA. And very soon, the idea of creating a home monitoring network for COVID-19 to help if hospital beds were unavailable was born. So there were two parts to what we did. One was, as we said, on the ground to do all the work. We contacted our community care through CHAD, LCC, USA, even through our conch department. And we also decided an information helpline, which was based in the main hospital, could be started. And what we did was this information helpline, we hope to have it 24/7, though I must thank the Vellore IMA for actually making it 24/7. We had it for most of the day and night. And these phone calls would be triaged to four arms, or four verticals as we call it: information, logistics, counseling, and clinical care. And this is how our poster went out with the number that we could call. I'll get to the telephonic part in a bit. So as I said, 4 arms and 4 training components. All this kind of happened within the next 10 days after the initiation of the idea. Training modules were created based on guidelines, local guidelines, government guidelines, Ministry of Health and Welfare guidelines, and WHO. Vetted and finalized. There was help from staff training in running multiple Zoom training sessions. So we pre-recorded orientation and training presentations, including case scenarios and audio files, because the entire conversation with the patient was going to be over the phone. We had to train ourselves to think differently. But the pandemic in the first way had already been a kind of training for most people. Staff were recruited and trained under all the forearms to work between their work schedules. Everybody did have some of their normal work along with UDHAVI. Then a help desk was created from more volunteers to coordinate between the patients and the helpline, just in case something happened that the patient needed to be contacted more, or we needed to supply something to them at home. An open WhatsApp group was formed to address queries real time. So any doubt would be popped and somebody would answer. And that was really a beautiful system because answers were just pouring into every query that came. And of course, a Google form was created after each call so that we could at least document what we did. And in case we needed to get back to the patient, then we would know what to do. Or if somebody else took the call later in the day for the same patient, there's already information there to help the patient with. So do remember we had these 4 lines. General information was regarding disease and vaccination. There was a medical arm for advice for patients who couldn't get a bed, who we would of course then refer to the home care services, both in the peripheral centers and under the Vellore IMA. There was counseling for patients and relatives who had the disease, and also for patients in palliative care of disease if they chose for that type of counseling. And there was a logistic arm organizing oxygen, bed management, and food for people in the community. So the telephone line, if a caller called the number, they would get Tamil or English and then go to the main menu. And the main menu, you could choose any of the arms that you needed and you would get help. And you could also move between arms, which was a way that was already instructed to the patient. They would log out of one arm, cut the call in one arm and easily go to the other arm if they wanted logistics after receiving medical care. So I'd just like to quote Dr. Anand, who was a part of our group and one of its main, I would say, inspires, that the UDHAVI embodies the concept of volunteerism, the helping hand reaching out at the point of greatest need, working together at a time of crisis, going beyond our comfort zone and responsiveness, and networking with a like-minded group. So it became known to the public as UDHAVI on 19th May 2020. Started on 1st, and by 19th, we were there to help. We were joined by Vellore's IMA's I, as their group was called IMAI, which Dr. Narmada has just spoken about. This was our reach, definitely within the district and also sometimes out of the district to other parts of the country. Just some stories. Mr. S, a 35-year-old laborer from Vellore, was advised home care. He was feeling very nervous. So he was, as his fever was persistent, so he called the UDHAVI helpline. He spoke to a doctor in Tamil and they was reassured. That was a general information line. He got advice on how to take care of himself and how to be in isolation. That was a medical arm. He even got a home monitoring kit delivered at his doorstep with thermometer, pulse oximeter the same day, and food rations were also given. That was from the logistics arm. And he subsequently got called every day by doctors in Vellore inquiring about his oxygen saturation and general health till he recovered. That was with our partners, the Vellore IMA, or under the IMAI project. Another story. Mrs. R was elderly. She was very clear she wanted to avoid hospital stay and her relatives agreed with it. Being under the coverage of the CMC community program, she reached out to the doctors who connected her to the UDHAVI outreach network. That was called as UDHAVI Connect. She was taken care at home and as per her wish was on home oxygen therapy supplied by the logistics arm. Though things turned worse, this was a decision she made and she wanted to be with her family. The counseling arm actually went to help till she peacefully breathed her last a week later. Her family was thankful for the empathetic care that was delivered at her bedside as per her wishes. This is some of the photographs of the home visits done under LCCU and also in Javari. There's a patient on being given an concentrator, there's a patient lying prone, and general advice. So UDHAVI is something close to the vision of CMC, being understood in a new way this time. So even as UDHAVI helpline became integrated to our own CMC hotline, the number doesn't exist, but the concept of UDHAVI remains. Where we should take it beyond COVID is something that we seriously think about, networking for other interventions, be it vaccination or providing healthcare not only in crises, but even in normal circumstances. So I thank you all for your patient listening, and it was indeed a successful and a very, very involved process. So I'd like to thank everybody who was involved in it. Thank you.